Thank you, Axel. It's a pleasure to be here. I hope everybody's enjoying their lunch. Just keep eating. Don't mind me. So I'd like to speak today about the toxicity of some of these agents, and I have some disclosures. First of all, we might try to define a little better what we're talking about. I think we're looking at the drugs that have been that are currently being used after all the standard approved drugs, including the chemotherapy agents and the targeted anti-VEGF and anti-EGFR antibodies. So the ones I'd like to talk about today are TAS-102, regorafenib, and nintedanib. So TAS-102 is really what I consider teaching an old dog new tricks. And this is Charlie Heidelberger, the same scientist at the University of Wisconsin who first synthesized 5-fluorouracil and then FUDR, fluorouracil deoxyribose, which many of us have used in regional therapy. But he also, in 1961, synthesized TAS-102, which is trifluorothymidine. So after deoxyribose, you put some additional fluorines on the uridine and you land up with this drug. The only problem was the half-life was like 12 minutes, so it was impractical. And the scientists at Taiho learned how to combine it with a metabolic inhibitor to give it a longer half-life. So you already heard about the mechanisms of action from Dr. Van Cutsem. It's actually incorporated into DNA as a false base, causing chain termination and DNA damage. You've seen the slide about the recourse trial looking at TAS-102 versus placebo, 2-to-1 randomization, 800 patients. And you can see here in the subgroup analysis, the forest plot, that all subgroups seem to benefit from this. And furthermore, if you have used regorafenib or not previously, as shown over here, you can see that the drug seems equally effective, and also if they were refractory to fluoropyrimidine in the last regimen, progressing on the drug, it was equally effective. So this seems to be a useful drug. And furthermore, the time to developing performance status 2, because everybody on the trial had to have performance status 0 or 1, was also significantly improved with a hazard ratio of 0.66, so about 50% longer. Now, in terms of toxicity, it's really interesting to see some of these data, because when we look at the placebo, all grades here, there's a lot of toxicity just from the cancer itself. That's what sometimes we tend to neglect, is that you have a lot of baseline side effects and even some grade 3 toxicity, which is not generally appreciatively different than what you see with TAS-102 for non-hematologic toxicity. They all look pretty comparable across the board for non-hematologic toxicity. However, when it comes to hematologic toxicity, especially the lab data, you see more differences where you have a higher incidence of grade 3 anemia, neutropenia, and thrombocytopenia with TAS-102 compared to placebo. And even though that is higher, you don't get particularly more febrile neutropenia, a little bit, 4% all grades, 3% grade 3 of febrile neutropenia, but not as high as the neutropenia rate itself. And what you find in practice, that mostly what you're seeing here are people who have kind of delayed marrow recovery, so they have somewhat grade 2 or grade 3 neutropenia. It usually takes an extra week for the white count to recover, given the current schedule that they've proposed, the 10 days on and then the 2 weeks off. And overall, serious adverse events were seen just as frequently in the placebo group compared to the treatment group, so that is worth noting as well. So it's a novel anti-metabolite combination, fluoropyrimidine nucleoside plus a metabolic inhibitor. There is not much non-hematologic toxicity. It looks quite a bit like placebo. Mainly the toxicity is hematologic, delayed marrow recovery. You can wait an additional week. And sometimes you need to use growth factor supports, possibly ESAs as well, and I think we're all very familiar with that. So managing the toxicity for this drug is something that we're all pretty comfortable with. So I'd like to move on to regorafenib, and again, as you've already seen today, it is a multi-targeted kinase inhibitor that has angiogenic inhibitory properties, including inhibition of VEGFR 1 through 3 and Tie2, tumor microenvironment by inhibiting PDGF and FGF, and also some oncogenes. So it has a wide variety of activity and a lot of kind of off-target effects. Of course, we don't know exactly what the target is, so maybe they're all off-target. But anyway, sorry, wrong way. So again, more graphically, you can see that by inhibiting FGF and VEGF, you get downstream inhibition of some of the canonical growth pathways. In the CORRECT trial, which you just heard about from Dr. Van Cutsem as well, again, about 800 patients were randomized 2-to-1, and you saw this slide as well showing that the waterfall plot looks appreciably different when you give regorafenib. So even though it's very difficult to see on the individual patient basis what the benefit is of the drug, overall a lot more patients have stable disease, though we don't see much difference in terms of actual PRs, but many more patients do have stable disease lasting several months in addition. And the survival benefit here is also pretty well consistent across the different subgroups. So the toxicity here does present a challenge, and one thing I can tell you, if you start at 160 a day or 120 a day, it doesn't matter, you can't just give the prescription to the patient or send it electronically to the pharmacy and say, come back and see me in a month. That is not going to work. You really need to stay on top of the patients for the first month. Particularly, you need follow-up phone calls and visits and really try to manage some of these early side effects. You can see here that hand-foot skin reaction, HFSR, is the most common toxicity with regorafenib. Almost half of all patients get some of this, 17% grade 1. Fatigue is common, as well as increase in diarrhea, hypertension, and rash. Anorexia is a little bit higher than placebo, voice changes. So these are some of the non-hematologic toxicities that kind of result in the challenges in management of patients on this drug. But as has been mentioned by Dr. Van Cutsem, the incidence of these grade 3 adverse events really does decrease over time, and this is not just due to dose reduction, because if you look at the dose intensity in the CORRECT trial, it doesn't change nearly as fast as the drop in these toxicities. This is really due to patients somehow coping better with it and they're getting past the initial biologic effects of the drug. So over the treatment cycles, the highest incidence is always in the first 2 cycles. Hand-foot skin reaction is the most common problem. This is not exactly hand-foot syndrome. This is also called PPE and plantar palmar erythema, erythrodysesthesia, PPE. Again, 47% of patients. It's a distinct variant of the more widely held hand-foot syndrome, and it's mainly seen in the areas that are under pressure or flexure, palms of hands, soles of feet, toes. It develops soon, 2 to 4 weeks after the patient starts treatment, and it is a challenge in management. So the symptoms can include all of these: dysesthesias and paresthesias, erythema, edema, dry or cracked skin, callus-like blisters. Those of you who heard Dr. Grothy earlier today saw a very nice picture of that, which I really need to get a copy of. Thank you, Axel. And intolerance to hot objects, so sensitivity to touching warm things. And this seems to be particularly due to when you have combined VEGF and PDGF blockade, which prevents vascular and tissue repair mechanisms. So that is a little different than hand-foot syndrome, which is considered more of a direct toxic effect. So hand-foot syndrome compared to PPE or HFSR. This is more symmetric and tends to be a little later. This can be more localized at areas of pressure, and it usually happens much more quickly. And this is the grading scale according to CTCAE version 4 and version 3. Grade 1, minimal changes. Grade 2, skin changes with pain. And grade 3, severe skin changes with pain. Or here, limiting instrumental activities of daily living. And here, limiting self-care ADLs for grade 3. And of course, as we heard from Dr. Grothy, there's another grade, grade W, which means when you have to go to Walmart. So that's the new modified CTCAE version 4.1. Some steps that you can use to help manage or lessen this, check hands, feet for calluses, rough spots, and remove them carefully. So you may need to have some dermatologists or orthopedic people help with that if they have bad calluses on their feet. Using moisturizing cream, avoid constricting shoes and gloves that rub the skin. Be careful when doing activities that irritate the skin, and avoid hot or warm water. Use cold water when they wash dishes and so forth. So these are some of the easy things that you can educate patients to help them get through this and prevent it. And again, this is the kind of thing that you want to have your nurse or your patient educator sit down and talk to the patient with. When you give them the prescription, you need to see them regularly during the first month. You need to call and see how they're doing. In terms of management of the toxicity, you can see here for grade 1, use of emollients and creams. For grade 2, you can use steroids such as clobetasol, and the creams as well, and topical analgesics, and decrease the dose by 1 tablet, using more supportive measures. And then you can restart. If it happens again, you may want to decrease the dose another 40 milligrams, and if it occurs a third or fourth time, then maybe discontinue. If it's immediately grade 3, again, topical therapy as well as steroids for symptomatic relief. Stop the drug, and then when you resume treatment, decrease by 40 milligrams the first one. If it happens again, then you can decrease a second time before you discontinue. Hand-foot syndrome, again, is something that we tend to see less of, but you can again see that interrupted dosing and then start again at a reduced dose and decrease vasoconstrictive agents. You can add pyridoxine, vitamin B6, topical therapies, lifestyle modifications. So again, for regorafenib, it's the first oral multikinase inhibitor. It did show improved overall survival, PFS, and disease control compared to placebo. Some of the side effects that we need to manage are non-hematologic, mainly hand-foot syndrome, hand-foot HFSR or PPE, fatigue, diarrhea, hypertension, and rash. You really need a lot more education and support of the patients and be in contact with them, as well as reducing the dose. Finally, I wanted to just mention nintedanib. This trial has been completely accrued. It's a 1-to-1 randomization of nintedanib, 200 milligrams POBID versus placebo. It goes by the catchy name 1199.52. They couldn't, well, actually there's some other name for it, Lux something or other, but they could have called it the NICE trial, nintedanib and colon, but anyway. So there are no data, so I can't really tell you about it, but nintedanib is an approved drug for idiopathic pulmonary fibrosis in the US and in Europe, and it's also approved for non-small cell lung cancer in Europe already. So in this randomized trial of more than 1,200 patients, this is all toxicity. There were very few grade 3-4 events and very few SAEs. You can see it causes a little bit more diarrhea, nausea, abdominal pain, but it's really quite mild. So, we're looking forward to seeing the data to see how effective it is and what the specific toxicity and management challenges will be with nintedanib. So we have 2 approved agents for refractory colorectal cancer which have been studied as a single agent. We're still awaiting study results from nintedanib. For TAS-102, it's fairly mild hematologic toxicity, mainly delayed recovery. For regorafenib, a lot of non-hematologic toxicity, but these can be managed better with patient education and some easy management tools. You just need to make sure that the patients are aware of these things and are engaged in the preventative process. And for nintedanib, we know currently that's reasonably non-toxic in other studies, but we still don't know what its activity will be. So, conclude. Thank you.